Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Podcast. Today I'm joined by Dr. Matthew Starr, Associate Professor and Residency Program Director at the Mayo Clinic in Rochester. We're going to discuss a manuscript of interest across the board in virtually all ophthalmology subspecialties, the approach to ophthalmic surgery involving the anterior vitreous, a clinical practice update from the American Society of Retina Specialists. Welcome, Dr. Starr.
Oh, thank you for having me. Happy to discuss this, important piece of literature.
So, Matt, we talk about this. We've been talking about this for literally since vitrectomy began. Can you take me through a little bit about your thoughts and your co-authors into why this was important and how you wanted to approach it?
Yeah, no, I think one, I had a great team, with all the co-authors on the paper. You have Dr. Layla Vizovich, Dr. Judy Kim, Michael Jumper, Kevin Blinder, Christina Wang, just an incredible team that really put it all together. I can't thank them enough. And really, the impetus was to kind of handle some of the complications that were arising. Maybe not published, but in retina clinics and retina operating rooms after some of these anterior segment vitrectomies were performed, and also kind of in response to some of the literature coming out surrounding short courses or brief courses aimed at essentially performing pars plana vitrectomy, comparing it to a vitreoretinal fellowship.
Yeah, that it's hard to imagine when our fellowships are 2 years of training after completion of the ophthalmology residency. Can you give me an example of some of the procedures and approaches that you felt were relevant to this topic?
Yeah, I mean, I think just first off, I mean, this paper wasn't meant to tell surgeons what they can and can't do. It wasn't meant to say some surgeons are doing things incorrectly and some surgeons should be changing their practice habits or surgical patterns. There's a lot of incredible surgeons out there doing all sorts of incredible things. I think the goal was to try to highlight the nuances of performing vitreoretinal surgery through the pars plana. As you stated, there's a reason that the surgical retina fellowships are 2 years long. There's a lot of complications. There's a lot of teaching. There's a lot of equipment that is necessary to perform these surgeries. And we wanted to really kind of highlight, the type of equipment that we're operating with, the differences in the, anterior vitrectomy platforms, that are, hooked up to the cataract machines. There's, completely different duty cycles, aspiration, flow rates. All of that is, very different cut rates. And in, it's, really wasn't supposed to, say again, some surgeons can't do what they're doing. It was just to kind of highlight, there's really some differences out there. Um, and, we were just seeing, some of these, anterior vitrectomy kind of complications arising, and we wanted to kind of put this out there.
Right. Well, it seems to me that, in a perfect world, if you had to operate on the vitreous, you'd want a vitreoretinal specialist. So examples for this would potentially be approaching what is presumed to be an uncomplicated cataract surgery and having capsular compromise and losing lens fragment or having vitreous prolapse. Is that really where the focus was, or did you see things more broadly? Because we're also seeing our glaucoma surgeons doing things through the anterior vitreous when they're placing valves posterior to the intraocular lens or the crystalline lens. I want to make sure our audience has an idea of what we're talking about, where we think we can help our colleagues.
Yeah, I think that we have taken the stance on, certain, secondary lenses. We feel that, complete pars plana vitrectomy is and should be performed. If you're going to put a, tube shunt into the vitreous cavity, a complete pars plana vitrectomy should be performed. There's a really nice paper that we discussed in this article by, Judy Kim, her AOS thesis, highlighting the, litigation risks of complex cataract surgery and surgeons that were essentially taken to settlement without any hope were those who did things outside of their scope of practice. Even one of them had some retina training and was still felt to be doing things outside their scope of practice when they had a complex cataract fail, doing what they deemed were a little bit risky procedures involving the vitreous. I think that the goal of this is to, again, not to say these surgeons should not be doing this. I have plenty of cornea colleagues and glaucoma colleagues who do a great job of doing an anterior vitrectomy through the pars plana, and they are very good. They are very safe, but they know what they're doing. I think to say that you can really kind of teach some of these things in such a quick fashion was a bit, again, the biggest kind of concern we had. Labeling some of these, surgeons as what we call, middle segment, surgeons, when in reality there's no middle segment of the eye. There's, the anterior chamber and the vitreous cavity, and I think that there's a reason that the vitreous base kind of straddles, the aura in the way it does, and there's a, certain nuances to that we are well versed in. I think that a lot of these procedures are, as you said, complex phacos, secondary lenses. Our concern was that if we, don't really kind of put, this out there, that some of these techniques that are being employed for, the cases we discussed may be employed for other things, such as, vitreous hemorrhage or floaters is our big concern there.
Right.
We're seeing a lot of problems, arising in the communities from, these floaterectomies doing, by non-vitreoretinal surgeons doing lasers or single port and floater removals, and that's a big problem.
Yeah, I think that the extrapolation of this concept that middle surgery is different than vitreoretinal surgery is kind of sad, because I look at that and think that the greatest complication profile for us is often right around the pars plana to pars plicata to retinal interface. And when you're doing this and you don't have good illumination and wide field viewing, it's very hard to be certain that you didn't have a potential inadvertent issue, right?
Exactly. I think that if you're doing some of these things without depressed exams at the end of these surgeries, without wide field illumination, endo illumination, or the ability to do laser, we talk about, oh, you can cryo and do indirect exams. That still takes a great deal of skill. That's usually a vitreoretinal kind of skill pattern. Again, not that, other surgeons cannot do that, but just there's things that they need to be cognizant of when you're violating the vitreous space, in that location.
Right. Well, I think that you've really done this a nice service by really explaining that this isn't telling surgeons what they can or cannot do, but really helping them to understand what that risk profile is for them. And I think Dr. Kim's thesis, looking at medical legal associated issues with this, really gives you an idea of what some colleagues are willing to comment about these procedures being done by non-retina specialty trained, ophthalmologists. And I do a little bit of medical legal work also. And I will tell you that it's not hard to imagine that if you weren't a retina specialist and you had a peripheral retinal complication and you were the one managing the surgical approach that caused the complication, it's very hard to defend.
Yeah, I think, again, just again bringing light to some of the concerns there and the potential concerns with labeling, middle segment and middle segment training. In reality, it's vitreoretinal surgery, which requires an intense fellowship. But like you said, we're here to try to just help. We want to do good by the patient. We want to put the patient, the needs of the patient first. We want to look out for the safety of them. We also want great outcomes, all understanding that it's nice if a single surgeon can do a lot of these surgeries, and it's nice to have, one surgeon doing the vitrectomy and the lens, or the glaucoma surgery and the cornea surgery. But in reality, a lot of times, maybe it's better off staged. Maybe it's better off, to come back to fight it, another day when you kind of you hit your limit of what is, perhaps safe.
Well, Matt, I also think you've said what is most important, which is that we're all interested in doing what is best for the patient. I think that if that needs to define every aspect of the clinical care that we do, not what's easiest always, but what is best. So, Dr. Starr, thank you for joining us and speaking to the ASRS's commentary on the approach to ophthalmic surgery involving the anterior vitreous. Pleasure to have you with us.
No, thank you so much for allowing me to be here and explaining this paper in more detail.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD Forum on the ASRS website to learn more. See you soon.